My name is Ulrik Lassen. I'm head of Department of Oncology at Subtitles, the Copenhagen University Hospital, and also professor in oncology with focus on personalized medicine.
My name is Bettina Ryll. I am the founder of the Melanoma Patient Network Europe, but I'm here actually in my other function as strategist for Vision Zero Cancer. And my interest for personalized medicine is mainly access for treatment options for patients who have no other options left.
Yes, so we have common interests because we work together in the EU-funded project PCM for EU in Work Package 5, and that's actually related to cross-border access. And why is this important in relation to precision medicine?
So we know that for precision medicine, often mutations are rare, and then you might just not be able to get the therapy in the place where you are treated. And we have seen this in our work in the Melanoma Patient Network Europe and also in other cancer communities, that patients who have no other options left are finding a trial, but the clinical trial is not available in their country. So accessing the trial in a different country is the only option to have access at all. And we have been, I have from personal experience, but we have also been helping patients to get to these trials and have encountered a number of difficulties. And that then means that only a few manage to achieve that. And that, of course, in terms of equity, is not a good outcome. What about you?
Yes, so I think in the project PCM for EU, where we really try to build up a network in Europe for what we call drop-like trials, that is trials where patients with mutations, where we can match an agent that actually is not approved for this indication but for another indication. We seek to test whether it works in this new indication. And therefore we match rare mutations, rare tumor type, drugs that are hard to get. So this network is very important. So we try to both expand the trial but also expand the possibility of patients undergoing genomic sequencing, so we can find out that they actually need this agent. And in order to get the evidence, we need to identify all patients with these rare mutations and make sure they get the right drug. So this is really a difficult issue because there are so large differences between some countries in Europe.
So from a patient perspective, that of course would be great. Now, you as an oncologist, I'm sure you have tried to send patients abroad or have received patients. Could you explain a little bit how that looks from your perspective?
Yeah, so in Denmark we have a completely public healthcare system. And actually we have a legislation of how we can refer patients for treatment abroad. Being a small country, we don't have all these highly specialized treatments. A few years ago we had proton therapy, but before that we didn't. Mm-hmm. So for instance, children with brain tumors, we could send to United States or sites in Europe to get proton therapy. So they didn't get long-term side effects when they grew up. And actually there was a certain way of doing that, and the same legislation also account for clinical trials. So if you have a patient, you feel that this patient could be matched to a clinical trial abroad, and you don't have the clinical trial in your country, then you can approach the investigator. If you can agree upon a collaboration to having this patient in this trial, then we have a body where we send an application. And when I send the application, I represent the highest expertise in this field from the university hospital. So when I say this would be the right treatment for the patient, then this national body, they review the application, and most often, if I can document that the trial is there and the site would like to receive the patient, then they approve. And then actually they pay for the travel and accommodation of the patient. And then we have the normal EU regulation, the S2 form, that takes care of other hospital-based expenses. For some clinical trials, actually pharma covers these things. So that's a way where we can actually send patients abroad. And of course, I'm aware of that, and I have some colleagues, but I'm sure not all.
Everyone's.
physicians in Denmark know this. And I don't know if the same is true for other countries in Europe, but I would anticipate that it is not.
We're sort of in a pitfall, in a gray zone. So according to our country's legislation, that is fully sort of possible, but that's sort of not intact. So it doesn't cover travel costs, travel reimbursement, and then the very other important thing is coverage of insurance if something happens within that sort of treating. So necessarily, let's say that the insurance usually for the specific trial covers anything that's related to the IMP, so the study drug itself. But let's say something else happens. So who covers that? So that needs to be sort of somehow written, boldly. And that's something we lack at the current moment. It would be really important.
If this situation happened for you previously, for a patient of yours, how did you deal with that?
Well, they've been very nicely covered in that country and also on our side as well. So because we have public health care, so the system takes care of it. Basically, like if you're having a vacation and might have a sudden heart problem or something, so of course that's taken care of fully.
What we have already done in this work package 5 is that we actually ran a workshop with European cancer patient advocates, first in April at the MPNE conference with colleagues from different types of cancers, but then again at a workshop at the Weekend Academy this summer, asking cancer patient advocates what mattered in terms of cross-border access to clinical trials for them. So what came up was what was a real concern on the patient side was the continuity of care. So people feared to be kind of lost in translation between two different centers, that their data and the information between the centers would not be forwarded, and that, for example, if there was a side effect, there was a concern that there was no one who would be responsible for them. So that was one part. The next one, the concern was what happens if this trial stops working? Will I be able to access back? So can I go back to my previous call? So that was one. The other was the concern, that's why I'm so interested in this, is the cost and the burden that comes not just for the patient but often also for the family. Mm-hmm. Traveling abroad, having access there, the accommodation and just organizing it. I mean, we travel both quite a bit, but not everyone is familiar and comfortable going abroad. And then you have the language problem and also cultural barrier. Could you tell me a bit how you deal in your setting with it? I mean, the cost covered is already fantastic, but there are other barriers. So how do you deal with the continuity of care and these concerns that patients have?
Well, I think that first of all, it is very difficult to send patients to treatment abroad if they don't have a family that can help out. If the patient is all alone, I think it's very complicated. If they go abroad, get a treatment, get side effects, they get treatment, but what's on the way home, they need somebody to take care of them. So that's really a problem. So discussing this and discussing alternatives, of course, the best option was that the patient can always be at home with the family, the caregivers, and actually we could be able to move the treatment to the patient. So that's another way. And of course, this is also something we are looking into in the PCM for EU project. And it's been discussed a lot in modern trial design, decentralized clinical trials. So of course, this is another way because it is a concern about who's taking care of the patients.
Experience has been very fruitful. Yeah. So we had a patient who had an AE while he was back home and he was in our trial. So immediately the treating physician contacted me and hey, we had to take the patient in, and I got the same day the sort of the already translated the courses or the sort of hospital slip on what had happened, and they kept me up to date. So it was very sort of fruitful in that, and we've tried to do the same since evidently our patient records are in Finnish, but that's quite easily translated. Yeah, and probably also there's an important aspect that they feel safe. Yeah. That you're going abroad, the culture is a little different, the language is probably a little different. The Nordic countries, it might be easier because many of us speak Swedish, but it's still not your mother tongue. But it's sort of like a safe feeling that you know that your treating physician is still in contact with your sort of study, because he or she is your treating physician in that specific trial, but you know that you're looked after. So that's also an important question for the patients when they travel abroad, and they have to remember that the disease itself may have a lot of symptoms. And
thanks that you mentioned that, because actually this Friday at ESMO I chaired a session on the caregiver's role in this process. And it was quite interesting. So there, if you look at the data, that apparently 20% of the general population are informal, up to 20% are informal caregivers, and what type of economic impact that has and how important it is for the patient. I had never considered that role in a clinical trial, which is a bit odd, having been there myself, because you're of course right. So how important it is to have a support system. So with that, I think we can already say that this is not going to be for everyone, and it's not our solution. It's a patch. It's something we can do now, but in the future we should move the trial to the patient, not the patient to the trial.
So one of the fields where it's working well in Europe is maybe in the pediatric setting with rare diseases, and of course then the children with some kind of disease. It can be cancer. It can also be other rare diseases. Of course, they have the parents and they have some caregivers with them, but being an adult, it's difficult, and much of the support also from the society is disappearing when a child is growing adult. Then there are completely different regulations. So that's a challenge. Another thing that is very important, that is, when we do the application in Denmark for such a cross-border treatment, then we have to document that we have a collaboration with the site, and it doesn't have to be a formal collaboration, but it's very important that when I refer a patient abroad, that I keep having responsibility of the patient, because when the patient is treated abroad, maybe they need some blood samples locally to follow up, and that's my responsibility. So I shouldn't just hand over everything. And we also receive quite a few patients from abroad for our trials, and we are completely dependent on the local investigators referring the patient, that they do what is required, so we are safe when having a patient at home and know that they are fit when they come for the next treatment.
To me, at least, since as we're also a small country, there's a lot of smaller molecular entities that we cannot cover within our country, not even the Nordics, so it was very keen and important to maybe distribute. And there's been also discussions on decentralized studies, so capabilities of kind of bringing the study to the patient. But I've had more experience on patients coming to our site from the other Nordic countries, and that has worked very well. There's I think good lessons to learn from Denmark, since they have the capability. So if the treating physician and the head of department recommend a specific trial, so the basis, the sort of the molecular or the biological basis or the rationale is strong enough, the patient can be sent so that his traveling costs are reimbursed, and even sort of the insurance coverage if something happens in that treating country. Yeah. So I have patients both from Norway and also Denmark enter our trials, and that has been rather convenient. There's evidently...
I think this is pretty much what the colleagues from the DICT, so the DRIP-like clinical trial community, have reported, because our colleagues in Ireland, so between Northern Ireland and Ireland, are trying to set up a trial together. We have a similar example between France and Switzerland, and one between Portugal and Spain, where actually all colleagues highlighted this importance, that to have clinicians on both sides who are also in contact with each other to ensure that this kind of, that the patient does not fall into the cracks. Yeah. So from my perspective on the patient advocacy side, what has happened is that patients have proactively found the clinical trials themselves, often having oncologists who were not aware of these trials. And some of them have organized the entire setup themselves. And we, in my personal case, that's what we did. So we reached out, and we have now helped other patients to do the same. But in that case, for example, you already mentioned S2. In that case, what happens is that the patient is liable for all the baseline costs abroad, while usually the top-up, the investigation side, is covered by the sponsor of the clinical trial. Yeah. And this kind of baseline can become prohibitive, especially if it comes with severe side effects and you might end up in intensive care. And at that point, it becomes really, really costly. So I think in that case, well, if you're desperate, you will take that risk. But I say, it's like, I did it myself. We did it for our own situation. I would never take the right from anyone to do so. But it comes with considerable personal risk to the patient, and I think that's not a desirable setting for any of us.
But I would also like to emphasize the importance of molecular tumor boards, because when you talk about the patient's responsibility to finding a trial, actually I think it's the physician. Of course, they are the advocates of the patients as well. They should find the best treatments. And this is also what we're looking into in the PCM for EU to have a way of having molecular tumor boards, because when the patients are sequenced, you need a group of experts discussing the results, and they should be the ones who identify, oh, this finding, actually, there's a drug that could match, and then find out where is this drug, and then go for it to see, well, there's a trial abroad maybe. So I think it's impossible for a patient to do this. Of course, when you're desperate and you look into internet and everything, but I think when you have the physician, treating physician, you have the genomic profiling, you have the tumor board, that's actually where the awareness could start about a new option for the patient.
Well, this is unfortunately not our experience. So in our experience, physicians or oncologists are aware about the trials running in their own institution. They already don't know about the trials in the next institution. Often there are personal animosities why they do not want to send a patient to a next institution, let alone abroad. If you send, the usually sending abroad comes with paperwork. That's not particularly, people don't like that. So we have seen the issue. In our community, for example, we regularly scan clinicaltrials.gov, I think where we all go, because the European database, for example, that we now have does not include academic trials. So you only have sponsored trials. If you want an academic trial, you have to go to the American site, and the European site does not help you. The American site often only lists countries as trial sites and doesn't give you the contact details of the investigator. So, but we usually know who, in my case, runs the melanoma trials in a country. So we know how to find out who the investigator is and how to track down the people to get people on there. So unfortunately, in our community, we have not seen that oncologists are proactive. Maybe that's also unfair considering what was this 7 minutes per patient? One cannot expect wonders. No. So we have a few. So it is very much dependent on the local oncologists, on how proactive they are, how active they themselves are in research, so how much familiar they are with the trial system. But we have not seen that this is something that's available for all patients. Yeah. Of course, that would be my preferred option. It's not what, I think to be fair, everyone should have access.
But I think it could be a role for the molecular tumor board, and maybe something that can also be looked into in the PCM for EU project.
That would be wonderful.
Because there are actually cloud-based solutions that are incorporated in many reports for profiling for tumor boards, where you actually can see a lot of listed trials and the clinical trial identifier and learn about it and have it in the report. I think that's the optimal solution, and this is what we should try to improve on a European level, to have this built in, I think.
So it looks like in the end we will have like a solution with many components. So some people will be sent abroad, independent of which mechanism. Ideally, we would rather like to have the trial going to the patient. We have to ensure that there's continuity between carriers, that we don't lose information, know how to deal with side effects. Yeah. So I think there's quite a list of pieces that have to fall into place before we really.
And awareness is so important, both about the trials, the drugs, but also about the legislation. How can you refer and make sure that there are some equal regulations throughout Europe? So maybe something we should raise politically in the European space.
I fully agree.